Hearing the words, "you have breast cancer," is overwhelming enough. Then comes a flood of medical terms that can feel like a completely foreign language. But here's the thing, understanding your specific type of breast cancer is one of the most powerful first steps you can take. It's the key to understanding your prognosis and building a tailored treatment plan. So let's break down the complex world of breast cancer into simple, easy-to-understand explanations. We'll explore the different types, what they really mean for you, and how this knowledge empowers you to work with your healthcare team on the best treatment decisions. First off, breast cancer isn't just one disease. Think of it more like a family of different cancers. We classify them in two main ways: by where in the breast the cancer started, and by the molecular engine that's driving it. Let's start with where it begins. First, let's talk about a crucial difference: non-invasive versus invasive cancer. Non-invasive, which you might hear called in situ, means the abnormal cells are still contained right where they started, like in the milk ducts. They haven't broken out yet. Invasive cancer means the cells have broken through the wall and can potentially spread to nearby breast tissue and even other parts of the body. To give you an idea of how common these are, estimates for 2025 suggest we'll see over 316,000 new cases of invasive breast cancer in the US, along with roughly 59,000 cases of non-invasive breast cancer. So, where does breast cancer most often start? In the milk ducts. This is called ductal carcinoma. When it's non-invasive, it's known as ductal carcinoma in situ, or DCIS. Now, DCIS itself isn't life-threatening, but, and this is a big but, it needs treatment because it has the potential to become invasive. When ductal cancer is invasive, it's called invasive ductal carcinoma, or IDC. This is the heavyweight champion of breast cancer types, making up about 80% of all invasive diagnoses. With IDC, the cancer cells that started in the duct have broken through the duct wall and are now growing into the fatty tissue of the breast. If you have found value in this video so far but are not a subscriber, please become one by subscribing to this channel. You will be notified when new health-related contents like this are published. The second most common spot for breast cancer to start is in the milk-producing glands, known as the lobules. This is called lobular carcinoma, and its invasive form, invasive lobular carcinoma, or ILC, accounts for about 10 to 15% of all invasive cases. Now, ILC is a bit of a different animal. Instead of forming a hard, distinct lump, ILC cells tend to grow in sneaky single-file lines. This pattern makes it much harder to feel during a physical exam and tougher to spot on a standard mammogram. Because of this, lobular cancers can sometimes be found at a more advanced stage. Interestingly, while patients with ILC can have better survival rates in the first few years compared to IDC, there can be a higher risk of it coming back many years down the road. Okay, so we've covered where the cancer starts. Now let's get into how it behaves. This is where we talk about molecular subtypes, and this is a game changer because it directly guides your prognosis and your tailored treatment plan. This all comes down to what's feeding the cancer. We look for three key things on the surface of the cancer cells: receptors for the hormone estrogen, ER, receptors for the hormone progesterone, PR, and whether the cells are making way too much of a protein called HER2. There are four main molecular subtypes. First up is Luminal A. Think of this as the most common subtype. It's hormone receptor positive, meaning it's fueled by estrogen and progesterone. But it's HER2 negative. These are typically slow-growing and have the most favorable prognosis because we have very effective hormone-blocking therapies to fight them. Next is Luminal B. These cancers are also hormone receptor positive, but they tend to grow faster than Luminal A tumors. They might be HER2 positive or HER2 negative, and because they are more aggressive, they often require a 1-2 punch of both hormone therapy and chemotherapy to improve the outcome. Third is the HER2-enriched subtype. These cancers are negative for hormone receptors, but are positive for that HER2 protein. This type of cancer is more aggressive and grows faster than some other types. However, the discovery of targeted therapies that go straight after the HER2 protein has been one of the biggest success stories in cancer treatment, dramatically improving the prognosis for patients. And finally, we have triple-negative breast cancer. As the name suggests, it's negative for all three receptors: estrogen, progesterone, and HER2. Triple-negative is considered more aggressive and has a tougher prognosis because those targeted and hormone therapies don't work, leaving chemotherapy as the main treatment option. So, how does this all fit together? A full diagnosis has two parts. You might be told you have an invasive ductal carcinoma, that's the clinical type, that is also luminal A, that's the molecular subtype. Or you could have an invasive lobular carcinoma that is also luminal A, which is actually pretty common for ILC. Knowing your cancer's subtype is crucial for creating a tailored treatment plan and understanding your prognosis. It explains why one person's treatment can look completely different from another's. But there's one more piece to the puzzle: genetic testing. Your diagnosis, especially if you have triple-negative breast cancer, might lead to a conversation about testing for inherited gene mutations like BRCA1 and BRCA2. This genetic information helps assess future cancer risk for you and your family members, adding another layer to your complete health picture. Ultimately, this knowledge is power. It turns a scary, confusing diagnosis into a clear path forward. If this guide helped clear things up for you, please give the video a like and subscribe for more clear, empowering health information. Feel free to share this with anyone you think might benefit from it. Most importantly, remember to always discuss the specifics of your diagnosis and treatment plan with your healthcare team. Thanks for watching.